Hi everyone. So from eyelids to the conjunctiva and now to the orbit. We always say orbit is a Pandora's box, and I'm just going to take you through very quickly um, how orbital tumors behaves. So these are my past and present affiliation, and this is my financial disclosure. When we talk about Pandora's box, we all know anything is possible in the orbit. It could be inflammation, it could be benign mimicking, a malignant lesion mimicking an inflammation, and vice versa. So it's so important to have a good clinical evaluation, imaging, systemic evaluation, and further appropriate management. And what we all need to know, I'm sure there are specialists here, there are orbital surgeons here, there are general ophthalmologists here. It's very important exactly to know when to refer these cases and for further management. Depending upon the origin, you can say that there are primary orbital tumors, secondary orbital tumors, which arises from the adjacent structures, and metastatic diseases. Depending upon the tissue of origin, it could be neural, it could be vasculogenic, mesenchymal, lymphoproliferative, arising from the lacrimal gland, histiocytic, bone, and cartilage. Now, this is what I always put up for many years, and this is for any trainees and postgraduate students. Depending upon the location, whether it's intraconal, extraconal, or both intra and extraconal, there is a list of tumors which actually helps us differentiate with imaging the type and possibility of a differential diagnosis. Now, this is a very interesting case which we saw few months back. This patient, 74-year-old lady, was referred for ptosis of the right eye. All right. It is very asymmetric, and it was referred as a case of aponeurotic ptosis, and she was having vision issues in that eye. Well, she has a frontalis overaction also there. But then what really remarkably, when I, just walked into the clinic, was there's some kind of fullness over here. There's some kind of puffiness, which is not very classical of a ptosis. And in an aponeurotic ptosis, although the lid crease is slightly high over here, but still there is some amount of fullness sitting over there. So this is not a straightforward case. And she also has a history of CLL. And she was not on any treatment. All right. Now, what we did was to image. So whenever there is a doubt, just go for imaging, whether it's ptosis, whether it's puffiness. And this is what we found. We could see this lesion, which is like really molding across the globe in the preseptal area, slightly extending towards the lacrimal gland fossa over here and into the anterior orbit. So obviously, we went ahead doing a biopsy. I went inside thinking that I'll do an incision biopsy, but the lesion was so nice. It was like really, wrapping up the globe. So we could take almost all of it, and this came out to be an extramarginal zone lymphoma. So this was a case of an anterior orbital lymphoma presenting as a ptosis. Now, how did we treat her? We did radiotherapy for her. We use ultra low dose radiotherapy. Now, the conventional radiotherapy dose is 2400 to 2500 centigrade. Now, something that I have shifted to in certain cases of mine, not all cases, is an ultra low dose, which is just 400 centigrade. So it's only 2 days radiotherapy. The conventional radiotherapy is 1 month radiotherapy, 15 in fractions, which will be like alternate days. But this is just 2 days. Patient goes to the doctor, gets 200 centigrade one day and another 200 centigrade one day, and then it gets treated. Now, she was still not happy. She was like a very energetic lady. She's like, what? I'm not liking the lower lid bag. Can I go for blepharoplasty? So finally, we landed up doing even blepharoplasty for her, and finally she was functionally and disease free and also cosmetically happy with whatever it was. So ocular adnexal lymphoma, I have put this case first because I don't want to miss out on the most common thing. Adnexal lymphoma, orbital lymphoma, is the most common malignancy of the orbit. It could be lymphoproliferative, it could be any spectrum, it could be reactive lymphoid hypoplasia to lymphoma. So we can have lymphomas occurring in the gland, in the lacrimal gland, in the muscles, Now, this is a patient who presented with bilateral lymphoma involving the lateral rectus of the right eye. You can see the fullness over here, and the lateral rectus and the inferior rectus of the left eye. So he received systemic chemotherapy because there was regional lymph node metastasis, and she received again local injection of rituximab and an ultra low dose radiotherapy, and it was bilateral. Now, when we have lymphoma, we just doesn't stop here. I'm sure Shruti is going to take you through. This is the battery of tests. There are still in certain centers where we get just a pathology report telling lymphoma. So that is not what we want. When it comes as lymphoproliferative disease and lymphoma, we really want to know what kind of lymphoma it is, whether it's a low-grade B-cell lymphoma, which is extramarginal zone mantle cell lymphoma, or high-grade diffuse large B-cell lymphoma. And according to that, we actually decide our management protocol. And this is the PET scan. All these patients undergo PET scan in order to rule out systemic involvement. This was a very interesting case. This was during the COVID times, which was referred to me when mucormycosis was going on. When he had uncontrolled diabetes, it was like 435 milligram per deciliter, the RBS, when he came in, and they thought probably it is severely painful. Patient was going in for a mucormycosis. Well, imaging I did, and I was not too convinced about mucormycosis. Why? Because the sinus was absolutely clear, right? Mucormycosis, you always know ethmoid sinus, and then it comes to the orbit. This was just an orbital lesion. So this mandates for a biopsy again, and not mucormycosis management. This came out to be a natural killer T-cell lymphoma with systemic involvement, and he couldn't. Well, we lost him for the disease despite starting him on chemotherapy. 45-year-old lady, epiphora of the right eye, 1 year. She had undergone endoscopic DCR, which was failed. She was in fact referred to me for DCR surgery, like a repeat DCR, because it failed with an ENT. Now, well, she had this over here, and when I palpated, it was more of firm in consistency. I was not too convinced about a dacryocystitis, a chronic dacryocystitis. Went for an imaging, and this was a lesion, a clover-shaped lesion that I found, and this was where the DCR was done. There is, interruption of the mucosa, and this was extending deep down there. So this came out to be, well, it was excised. I went in for a surgery, a diffuse large B-cell lymphoma. Interesting case again. This was a patient who was referred as a case of myositis. So this is a right eye, and there is enlargement of the medial rectus muscle over here. Extremes of age, we have to be always very careful in orbital disease or any cancer. So patient of this age, 78-year-old lady presenting with this muscle enlargement, what I would do first is to go and do a systemic evaluation, all right? I did do a systemic evaluation, and this is what I found. She had a breast mass, where in fact she has not discussed with her family, scared of the situation, and this was the first time that, so I didn't even do a biopsy in her, because I know this is a metastasis into the orbit. So it was a breast CA metastasizing into the orbit. 50-year-old gentleman, pain and redness in the right eye, 2 years, proptosis. Well, I was so sure seeing this, it is a case of lymphoma. There is a large feeder vessel over here. It has got a salmonish color. He has a lesion over here. And this is his imaging. Diffuse lesion. And I thought, of course, it's like kind of molding the entire globe, but pretty diffuse. And I said, okay, if I have to prove, let me go debulk and then prove it's lymphoma and then go for management. So this was what we got. Spindle cells. Completely different, right? Sorry? Yeah, very nice picture. Thanks to Kaustubh. Predominant lymphocytes, lymphoid nodule, and immunohistochemistry was done, and it was positive for IgG for plasma cells. Where in the clinic, I was so sure that it's lymphoma, but it turned out to be an inflammatory disease. And his serum IgG4 was also very, very high. So in Orbit IgG4 related disease, oral steroids, he received oral steroids, intravenous methylprednisolone, and he's on a long-term azathioprine, and he's doing fine. So the role of orbital, this is what I really want to highlight here. The role of orbital biopsy is so crucial, because 30 to 40% of the biopsied inflammatory disease has a specific disorder. Whenever in doubt, just go and take a biopsy, be it even an incision biopsy. And if you find something which has come odd, refer the patient. Lacrimal gland adenoid cystic carcinoma is something that I want to highlight in this brief time over here. This was a 52-year-old gentleman, bulgy eyes, recently noticed, and he came for a second opinion because this is a triradiate lesion where you have it in the orbit, you have it in the temporal fossa, and the bone is sclerotic over here. So he was referred as a case of possible meningioma. Well, I also thought it could be meningioma, but went and did a biopsy, and it turned out to be a lacrimal gland adenoid cystic carcinoma. And why I want to highlight it here, we had published on this, and the current protocol is a multimodal treatment protocol that we give in these patients. We give neoadjuvant chemotherapy. We kind of chemo reduce it. After chemo reducing, the entire tumor, as much as possible, is taken out. Then we radiate, and then we give adjuvant chemotherapy. So we had this, publication. Even SEMA is part of this. What we have found, very good results in terms of life salvage, systemic metastasis, local tumor recurrence, and even secondary outcome like salvaging the eye and vision salvage in these patients, and it's really helped. But despite this, we still find patients like we discussed recently, like in 1 month we have seen 2 patients where the management was mismanaged, where orbital exentration was done in a patient, and then with a bad outcome, and another patient where again just an incision biopsy was done, directly sent for radiotherapy, and it recurred like a huge mammoth tumor. So I think this is why I really want to highlight this. If it's adenoid cystic carcinoma, this is the current protocol. Now, patient with a very subtle proptosis, this is the fundus picture. You have the tram track sign over here, and that is optic nerve sheath meningioma. We can also have sphenoid wing meningioma, as in this case, and what we do is a radiotherapy linear accelerator. Now, there are certain types of meningiomas, optic nerve sheath meningioma. There is a variety called malignant optic nerve sheath meningioma. This was like a patient who presented with severe pain, constant pain, completely blind eye, CRVO, CRAO, everything happening in the fundus, and this is the meningioma that she had. So, in fact, we went ahead enucleating with a large tumor and gave her a good prosthetic eye. Now, coming to this patient, 3-month-old baby girl and a 23-year-old lady presenting with these orbital lesions, where both turned out to be a rhabdomyosarcoma. So rhabdomyosarcoma is a malignancy of childhood. We usually see around 8 years and 10 years of age, but this was completely different in a very young child and an older individual. That's also possible, and this is also done as a multimodal treatment protocol. Now, what I want to highlight here is group 1 is a good group, group 2 is a good group after biopsy. Now, how does it become good? With complete tumor removal, the prognosis is excellent. Microscopic residual tumor, the prognosis is excellent. But when you leave behind in these patients a larger chunk of tumor there, then the prognosis is really bad. So as a surgeon, make sure that you kind of remove this tumor as much as possible. Orbital venolymphatic malformation, lymphangioma, we often see it. This is a patient, in fact, as you can see here, this is a venous malformation. It is a varix over here. What we do is bleomycin, and this is how we inject bleomycin. We aspirate the blood and then we inject into it, and patient does well. So we don't have much time to kind of cover the entire spectrum. Ocular vascular anomalies and orbital vascular anomalies have, we have navigated to better treatment modalities, which is much more local. Pediatric, this is a pediatric patient presenting with a larger lesion sitting here, where, it is an orbital teratoma, complete surgical excision, whereas in an optic nerve glioma, we go for non-surgical approach, that is systemic chemotherapy, and it's mostly a clinical diagnosis. Update on optic nerve glioma is systemic chemotherapy. You should not leave it behind, not treating it. And if you leave it behind, this is how the consequence would be when the child grows, as a child grows. And with systemic chemotherapy, you can really control the tumor. And this is what happened to a child where the treatment was not started on time. 10-year-old girl, proptosis, diplopia, rapid progression, was sent with a very trivial history of trauma as retrobulbar hemorrhage. Well, it turned out to be an Evic sarcoma and a PNET. Again, these patients, malignant orbital tumors, always we prefer a multimodal treatment protocol. Recurrent swelling of the eyelid on and off. You can see there is a lesion. There is erosion of the bone, which is a very simple lesion, and this came out to be an eosinophilic granuloma. Whenever there is an erosion of bone, we get scared that there is some malignancy going on in there, but it's a recurrent swelling on and off, and this is how she was treated with intralesional injection of triamcinolone acetonide with curettage that I did, and she did pretty well. So coming to the end, the last 2 slides, orbital neoplasm management, there are non-surgical approaches, and you can decide if your diagnosis is dot on. You don't have to go and take out the entire lesion in certain lesions which is very diffuse. You can just go in and do an incision biopsy, and well, of course, if it's a very well defined lesion, you go for an excision biopsy like cavernous hemangioma, like schwannoma, and solitary fibrous tumor. Now, when not to enter the orbit, like a child presenting with proptosis, you just have to do a peripheral blood smear, and this came out to be a granulocytic sarcoma. You don't have to enter the orbit if it is a lesion sitting in the apex of the orbit, like hemangioma, cavernous hemangioma like this, then it's gamma knife. Then stenting and coil embolization in proptosis when there is fistulas, cavernous fistulas. You can also have inophthalmos in orbital tumor, need not be always proptosis, such as this in a varix where you can have inophthalmos, and also in metastasis like serous carcinoma of the breast where you can also have inophthalmos. So this is something that you should not be scared of as an orbit, but a thorough evaluation will give you some idea, and if at all you're not really sure about it, please don't shy away from referring these cases. Thank you so much.